another kind of glomerulonephritis, which is IgA nephropathy. So IgA nephropathy is also called as Buerger's disease. Remember, Buerger's disease was something else, TAO, right? See, TAO we saw in vasculitis chapter. So that had a U. Here in IgA nephropathy, U is not there. It is just BERGER. So Buerger's disease is also called as IgA nephropathy. And this is the most common glomerulonephritis as such. So nephrotic nephritic syndrome, if you don't classify it, it is the most common one. And this is also the most common cause of recurrent hematuria. The patient will have a history of recurrent hematuria post some infection again. So 1 to 4 days after a respiratory or a GI infection, the patient is going to present with recurrent hematuria. And here there is going to be some aberrance of the alternate complement pathway here. So A stands for A, IgA nephropathy. So A here. So alternate complement pathway, again A here is going to be activated. So what is actually happening here? Suppose this is the IgA immunoglobulin, if you consider, especially the IgA1 isoform. So here this is the hinge region. So against this hinge region, autoantibodies of the IgG class are going to be directed. So autoantibodies are going to be directed against the hinge region of this IgA1 subtype. So that is going to result in some aberrance of the alternate complement pathway again. And this IgA nephropathy is going to be associated with certain diseases like celiac disease, Henoch-Schönlein purpura, and liver diseases. Okay, and here again recurrence can be seen in 15% of the patients. And what is the classical feature? Here again there is going to be mesangial deposits along with mesangial proliferation. So mesangial proliferation with mesangial matrix deposition. So in this image, if you see, these are all the endothelial cells, while this pink material in between, this darker pink material in between, this is all going to be the mesangial proliferation along with the mesangial cells. Okay. And on immunofluorescence, this is the first time we are seeing mesangial immunodeposits, right? So granular was kind of dot like appearance. Linear was all ribbon like, while this is going to be present in between, like some mass you are seeing in between the capillaries. So this kind of immunofluorescence was that of a mesangial deposits seen in IgA nephropathy, and also yes, fibronectin kind of glomerulonephropathy also had a mesangial proliferation and mesangial deposits. So the next one will be an Alport syndrome. Alport syndrome, here it is actually a hereditary nephritis. So family history of this recurrent hematuria again will be present. Here again the presentation will be recurrent hematuria. But Alport syndrome as such will have a classical triad of hematuria along with sensory neural hearing loss, and also in eye they'll have lenticonus, anterior lenticonus. So this classical triad is that of a Alport syndrome, and it can have all kind of inheritance, especially X-linked dominant. So X-linked dominant is the most common kind of inheritance. Other than that, you can also have X-linked recessive, autosomal recessive and dominant patterns. Okay, and each of this inheritance is going to lead to some defect. Okay, suppose in X-linked, so here also the type 4 collagen of the base membrane is only going to be affected. That is, the base membrane is affected here, but the alpha 5 chain will be affected in X-linked. While in autosomal recessive and autosomal dominant patterns, it is the alpha 3 and alpha 4 chains affected. Okay. So, if you remember, we had already discussed something related to this. So, in Goodpasture syndrome, again, it was type 4 collagen, NC1 domain of the alpha 3 chain. So, alpha 3 chain was affected in Goodpasture syndrome, while all the 3 chains, alpha 3, 4 and 5 are going to be affected in Alport syndrome. Okay. And here the age group affected will be a younger age group, young adults like 5 to 20 years, child or adolescent age group, and they'll present with hematuria with RBC cast, and here they can also progress on to chronic renal failure. So diagnostically, if you see a light microscopy in immunofluorescence is not going to be of much use. Only on electron microscopy you can diagnose Alport syndrome, and the classical feature on electron microscopy will be that of a basket weave appearance. So here there will be alternate thickening and thinning of the basement membrane. So in this image, if you see, so this entire part is going to be the basement membrane. Okay, so here it is thick, while in here it is very thin. So this kind of alternate thickening and thinning part of the pattern of base membrane is going to be seen in Alport syndrome. And also, if you see clearly see in this thickened part, it is having some laminated appearance in the base membrane. So this kind of laminated appearance of the basement membrane is also called as basket weave appearance, and that is the classical feature of an Alport syndrome. So since we are speaking about basement membrane, we have very few diseases which were as such affecting the basement membrane. First was Alport syndrome. Second was Goodpasture syndrome. Third one will be a thin basement membrane nephropathy. So this is also here the basement membrane is actually very thin. In Alport, it was thin and thick alternatively, but in thin basement membrane nephropathy, as the name suggests, it is going to have a very thin basement membrane. So the normal basement membrane thickness was 300 to 400 nanometer. However, in thin basement membrane nephropathy, the thickness of the basement membrane is going to be markedly reduced to around 200 nanometers. And here the alpha 3 and alpha 4 chain of the type 4 collagen is going to be affected. So 3 chain for Goodpastures, 3, 4 for thin basement membrane nephropathy, then 3, 4, 5, all 3 for Alport syndrome. Okay, remember it like that. So other than that, only other disease in which we had a membranous kind of deposit was dense deposit disease, which was basically type 2 MPGN, in which alternate complement pathway was activated. Okay. So the next example of this will be glomerulonephritis will be a lupus nephritis. So systemic lupus erythematosus can have a very systemic kind of manifestation, and one of the features will be that of a kidney manifestation. In kidney, it is going to produce nephritis, and here it is going to have, we are dividing the nephritic pattern into 6 classes. So the first pattern will be minimal mesangial lupus nephritis. Second will be mesangioproliferative. Third class will be focal proliferative. Fourth will be diffuse proliferative. Fifth is membranous lupus nephritis, and sixth will be sclerosing lupus nephritis. So depending on the severity, the class is going to increase. So the very first one, which is minimal mesangial nephritis, is going to have the best prognosis, while the sclerosing lupus nephritis is going to have the worst prognosis. And the most common class in which the patients present with will be a fourth class, which is diffuse proliferative lupus nephritis. So this is the most common class. And also the classical feature you see in lupus nephritis will be a wire loop lesion. So wire loop lesions are nothing but subendothelial deposition. So SLE, we all know it is an immune complex mediated disorder, right? And it was an example of both type 1 and type 3 hypersensitivity, most commonly of type 3 hypersensitivity, right? So in type 3 hypersensitivity, there is going to be immune complex deposition, and here the location of the immune complexes will be on the subendothelial location. So subendothelial location deposits will give a classical feature of wire loop lesion. So these are the wire loops seen here. So in this image, if you see, this is all the normal glomerulus, but here if you see, it is all thickened around the capillaries. You will having a thickened kind of appearance, and these are called as wire loop lesions. And wire loop lesions can be seen in classes 3, 4 and 5, but most commonly in the class 4, which is also the most common kind of pattern of lupus nephritis. So diffuse proliferative lupus nephritis, you see wire loop lesions most commonly. And other than that, being an immune complex disorder, you are going to have granular immunofluorescence. And the most important thing about SLE will be the immunofluorescence can be demonstrated with all kind of immunoglobulins and all kind of complements, basically IgG, IgM, IgG, IgA, C3, every kind of thing you can put. So, and that is why it is called as full house effect. Okay, all of it is going to give, it's going to react. So, it's called as a full house effect, and the deposits were subendothelial deposits. The number of wire loop lesions will also depend upon the number of subendothelial deposits, and that will determine the severity of the disease as well. Okay, so till now we have seen about the nephritic and the nephrotic syndromes basically. So when you are approaching, and every year they usually ask one question from kidney, usually from glomerulonephritis. So when you are approaching the case, you first see whether they are giving history like that of a nephrotic kind of syndrome or a nephritic kind of syndrome. So based on the hypertension, hematuria, proteinuria range, you can diagnose that. Then you will see the age of the patient, whether it is a child or whether it is a adult. So in child, what all conditions you'll have to think about? Minimal change disease, which is a nephrotic syndrome. Then you have to think about HSP, Henoch-Schönlein purpura also, which is a vasculitis condition. So there you'll have joint pain, that is IgA related nephropathy, right? So joint pain, abdominal pain, along with the hematuria will be present with palpable purpura. So in child, you'll have to think like that. And in adult, if you are giving history of recurrent hematuria, then think about Alport syndrome or that of IgA nephropathy. Usually IgA nephropathy, because Alport syndrome usually 5 to 20 years of age group will be the limit, and Alport since it is a hereditary hematuria, here there will be some kind of family history given. So that will lead on to Alport syndrome. Other than that, if they are mentioning some elderly or an adult kind of age group, then you look for other secondary causes. If they are mentioning something like a hepatitis association or some autoimmune kind of conditions or connective tissue disorder history is being given, or infectious condition is being given. So that kind of thing you'll have to look for. So that will lead to give a clue to either an MGN or a MPGN. So there again you'll have to see about the features on image based questions. So what are the features given, whether they are giving a tram track kind of an appearance or a spike and doom kind of appearance. So based on all of these features, you can come to a diagnosis definitely. So approach the case with this kind of a systematic pattern.